So thank you. Before I start a talk, I should thank you, Dr. Vitul, and the entire MAPICON organizing committee for giving me such a honor to present this small talk on a patient approach to a patient with interstitial lung disease. It will be a concise, evidence based, informed clinical guide. I will try to short it as much as possible. So, don't worry, but I try to be on time. So, what are the learning objectives from today's talk? It is basically understanding the classification and the common causes of ILD and recognizing the key HRCT patterns and their diagnostic implications. Outline a stepwise diagnostic workup like histories, PFTs, HRCTs, serology and pathology. Reviewing the contemporary management strategies including antifibrotics, immunomodulation and supportive care, and how to monitor, how to referral criteria and the prognostic factors in the ILD. So what is an ILD? These are basically not a single disease. It's a group of 200 disorders causing a inflammation or fibrosis of a lung interstitium. It ranges from reversible inflammatory disease to a progressive fibrosing ILD. So what are the key concepts? Basically, it has clinical, radiological and pathological patterns which basically label a every separate ILD, and they helps in guiding the diagnosis and treatment of that particular ILD. All ILDs are not same, all ILDs, the treatment is not same, the investigations are not same. So the epidemiology, incidence and prevalence are always vary by region and subtype. In India, the most common cause of ILD is hypersensitivity pneumonitis, but all over the world, the most common cause is the interstitial pulmonary fibrosis. Out of that, the progressive fibrosing phenotypes, they carry the highest morbidity and mortality. And the timely diagnosis of these diseases improves the management options and outcome. So these are the classification of ILD. Will not go into too much of detail. The most important being is these are the idiopathic interstitial pneumonias. So all of these lists in IIPs, basically these are idiopathic interstitial pneumonias. It includes idiopathic pulmonary fibrosis, idiopathic NSIPs, RBILD, desquamatic pneumonia, cryptogenic organizing pneumonia, earlier it was called as BOOP, then acute interstitial pneumonia, idiopathic lymphoid interstitial pneumonia, idiopathic pleuroparenchymal fibroelastosis, and other unclassifiable ILDs. Second most important classification is the autoimmune ILDs. Autoimmune ILDs like in Sjogren syndrome, SLE, rheumatoid arthritis, systemic sclerosis, mixed connective tissue disorders, polymyositis, dermatomyositis, all of these can cause various presentation of ILDs. So these are radiological presentations like cryptogenic organizing pneumonia, NSIP, UIP. So all of these, if they come in a CTD, in a connective tissue disorders, we label it as an interstitial pneumonia or an ILD with autoimmune features, something like that. So all of these has a different treatment lines. Then coming to hypersensitivity pneumonitis. Hypersensitivity pneumonitis is the most common cause of ILD in India. The most common being the farmer's lung and the pigeon breeder's lung, basically to the bird proteins. And it is a specific hypersensitivity reaction to a bird proteins. Then we have another set of ILDs, sarcoidosis. Sarcoidosis is entirely a different ball game, a totally a different disease, but it is also a ILD, but it has a granuloma as a specific feature. Then other ILDs like lymphangioliomyomatosis, specifically in ladies, then Langerhans cell histiocytosis in males. Drug-induced ILD like codron, amiodarone can cause drug-induced ILDs, bleomycin, busulfan, anti-cancer drugs, all of these can cause drug-induced ILDs. Radiation can cause drug-induced ILD. Even paraquat oxygen, sometimes high amounts of FiO2 can cause a drug-induced ILD. Then ILD is related to occupational exposures like silicosis, pneumoconiosis and other asbestosis. Then we have ILDs related to vasculitis and granulomatosis diseases like we have in Churg-Strauss and Wegener's granulomatosis. And then there are a lot of other rare ILDs. So we will be only going into the common ILDs, what we found in our country and we in routine practice. So what are the clinical presentation? I think everyone knows the symptoms are same: progressive exertional dyspnea with a non-productive cough, fatigue, and signs specifically, classic signs are bivascular velcro crackles, but they may not be present in all ILDs, but if they are present, they are very characteristic of ILD. Then digital clubbing, oxygen desaturation on exertion. Already if there is an oxygen desaturation on rest, if the saturation is less than 90% on rest, then you may think about it as the disease is already far more progressed. But most of the diseases in OPD practice, you can see if you just take patient to walk, do a 6-minute walk test or some exercise, they will have a desaturation. What are the red flags in ILD? In clinically, always important to see in OPD practice is the rapid progression. Any rapidly progressive ILD, it is a red flag. Then any significant hypoxemia, I have already told, if your baseline saturation is less than 90% in OPD, then definitely that is a red flag. Then any hemoptysis in ILD. Hemoptysis is not the symptom of ILD, but if there is a hemoptysis, there may be some complication or some vasculitis that already has developed. Then any systemic signs suggesting CTD. Systemic signs means if it is a systemic signs, that means the disease may not be only involving the lungs, disease may be involving other organ systems like kidneys, liver, brain, cardiac, like in sarcoidosis or CTDs. So any systemic manifestations are red flags. Now coming to the history and examination, always take a detailed occupational history. Very, very important history. What we found is, if I see a suspected ILD in our part, especially in Punjab, always ask for, one is the occupation is the farmer's lung and the second is bird fancius. I have seen this disease in pigeon breeders. Here in like areas around Bathinda, you will see a lot of rural population, even in urban population, people keep pigeons as a recreational purposes for different, they play with the different games or do a betting on with their on the pigeons. So they have like 200, 250 pigeons somewhere in their own house. Most of my hypersensitive pneumonitis I have seen the exposure to pigeons is significant. So that is the most important thing. And second history you always take is, I have also seen it in poultry farms. So people working in poultry farms are owning a poultry farms. So there also the exposure to bird feathers are pretty high. And so these are the common occupations in our part. Outside Punjab, you can see coal workers, silicosis, asbestosis. You have to take the different occupations in mind. Then coming to environmental, we have already discussed about the farmers and the pigeon breeders. Coming to the drug history, Codron is very commonly used. So always take a drug history of Codron. Always take a drug history of methotrexate, bleomycin, busulfan, all of these drugs. Any background history of radiation. Sometimes I see in practice radiation pneumonitis in a patient who was having a breast cancer some 20 years back, got some radiotherapy later on, and then you see a particular ILD in that particular on single side. Then you most probably you can correlate with that drug or a medical history. Then smoking history. If patient is smoker, the chances of IPF increases. Idiopathic pulmonary fibrosis, 90% of idiopathic pulmonary fibrosis are smokers. It is very difficult to label IPF in a non-smoker patient. Second is Langerhans cell histiocytosis. Most of these patients are smoker. Good pasture syndrome, these patients are smoker. So all of these diseases, they have a very, very strong association with smokers. Now coming to exposures to birds, molds, hot tubs, we have already discussed this. Then important thing is systemic symptoms. Systemic symptoms, especially in connective tissue disorders like presence of arthralgia, presence of Raynaud disease, presence of rash, presence of salt and pepper appearance, presence of any small joint pains, sclerodactyly, other skin thickening. All of these are very, very important. Whenever we see an ILD, the first thing we see, all of this systemic manifestation, at least 10-20% of the ILDs, you will have some connective tissue clearly sitting there. Now coming to the initial investigations, most important investigations are CBC, we all know, renal, hepatic panels, autoimmune serology like ANA. ANA should always be done by immunofluorescence and not by ELISA. That is a recommended thing. And if ANA is positive, it should be followed by ENA profile where all the antigens should be worked upon, and even a myositis panel should also be asked for. Then anti-CCP and RA factor for ruling rheumatoid arthritis. Then for the functional status of the patient, we have to do the baseline saturation, 6-minute walk test, pulmonary function tests including a routine spirometry to look for FVC, and diffusion capacities to look for DLCO. This is the minimum workup that has to be done in all ILD patients. Now, most important thing in an ILD after the basic investigation is the CT. The entire treatment, the entire management of ILD is based on HRCT. There is a significance of pathology also, but the most important test, if somebody asks you which is the most important test, the entire ILD is sitting on basically the role of HRCT. So every ILD should be subjected to HRCT. So what are the high resolution tests which are pattern recognition? The pattern recognitions are UIP, NSIP, OP. Will go into this. HRCT can allow a definitive diagnosis of IPF when definitive UIP is present in a particular history. It also describes the distribution, whether a disease is subpleural versus peribronchovascular, extent of the disease, the extent of fibrotic part of the disease, and features of activity. The more the fibrosis, the disease progresses, already there is a significant disease progression and patient may not respond that well to treatment. If there are features of activity, then whatever treatment you are offering, there are chances that this patient may clinically and pathologically respond to this particular treatment. So that is, it also helps us in the looking for an extent of damage and also the prognostically. So before going into the different presentation, you should know this slide. This is the most important slide on HRCT. So what are the different presentations? So you should know. So any ILD, either you see a lot of ground glass, so this is the ground glass, you see a lot of ground glass, or you see a disease here somewhere down in the subpleural areas, you see a honeycombing. Any presence of honeycombing in subpleural areas, it is a sign of fibrosis. More the honeycombing, the higher is the progression of disease, and lesser you can expect a treatment results in this patient clinically as well as radiologically. Now coming to, these are the nodular patterns. You see these are small nodules. Nodules you will see in hypersensitivity pneumonitis or sarcoidosis. This honeycombing you will see in UIP, in IPF. Ground glassing you mostly see in either diffuse alveolar damage like presentations of ARDS, or you see in NSIPs, non-specific interstitial pneumonia, or like in CTDs, connective tissue disorders. Then you may also see a parenchymal consolidation. It is a classic consolidation we see in bacterial or viral pneumonias also with the air bronchograms, and you can see a atoll sign, a halo sign, a pseudo halo sign basically. So that is called as atoll sign. These are classical of BOOP, cryptogenic organizing pneumonia. So the entire patterns of different ILDs sits on these 5 or 6 radiological presentations. Now coming to the various idiopathic interstitial pneumonias, we'll not go into too much of detail. The most important being, it is UIP and NSIP. So these are the, you should know what are the UIP and NSIP if you are going into any lecture on ILD. UIP is usual interstitial pneumonia, NSIP is non-specific interstitial pneumonia. Please don't go by the names. These are just names, somewhere come from some previous nomenclature. It doesn't mean there is anything usual, or it doesn't mean there is non-specific. It is also a very specific disease. NSIP is a very specific disease. Just they have labeled a name as NSIP. And the usual interstitial pneumonia, there is nothing usual in that. So these are just names which are running on, but you should know these two different patterns. The most important difference is in UIP you see lot of fibrosis and less of inflammation. In NSIP you see lot of inflammation, less of fibrosis. That is the most important crux. In UIP, since there is lot of fibrosis, these patient doesn't respond much to treatment. The treatment options are also limited. You don't give too much of immunosuppressives, you don't give too much of steroids. You may offer them antifibrotic therapies like nintedanib, pirfenidone, some of these drugs. In NSIP, since there is a lot of disease activity, there is a lot of inflammation, you may offer these patients steroids, immunosuppressives like azathioprine, methotrexate, mycophenolate, all of these drugs. In the subset of patients, these drugs may have a significant role, including steroids. So, most important differentiation is bilateral reticular opacities are present in UIP. Ground glasses is not prominent, absence of ground glassing, and it is basal and subpleural predominance. There will be a fibrosis and honeycombing with or without traction bronchiolactasis. Any presence of traction bronchiolactasis is also an indicator of airway, small airway fibrosis. Coming to NSIP, there is bilateral reticular opacities, there is lot of bilateral ground glass opacities, there is basal predominance, it is diffuse, subpleural, honeycombing is minimal or absent. There may be traction bronchiolactasis. The most important differentiation is the ground glasses versus honeycombing. In this UIP, you see a lot of honeycombing. In NSIP, you see a lot of ground glassing with absence of honeycombing. So this is the most important differentiation. And okay, this is how it looks like. So this is a UIP pattern. Subpleural honeycombing you see in a basal regions. This is the classic UIP pattern. And in NSIP, you see a lot of ground glassing. You see a lot of consolidations or ground glassing in NSIP pattern. So these NSIP patterns respond much better. They have a better prognosis compared to any disease coming with UIP. Then coming to OP. OP you see a lot of consolidations, and you may also see a Atul sign. So dense consolidation, it will appear like more of an infective disease. It may also look like a tuberculosis or any other infective non-tubercular mycobacteria or some lingering on infection. But cryptogenic organizing pneumonia, these respond beautifully to treatment. This is one of the ILD. If treated well, their HRCT may come back to normal. So it means cryptogenic organizing pneumonia, it is one of the few ILDs which may be completely reversible. It's very, very rare to have a reversible ILD. Cryptogenic organizing pneumonia is one of them. Then you have a different combinations like NSIP plus OP. Then one more important thing you should know is DAD pattern. This is called as diffuse alveolar damage. Lot of ground glass consolidations throughout the lung fields. This is present, this DAD pattern is present in good pastures. This is present in ARDS. This is also present in acute interstitial pneumonia, previously called as Hamann-Rich syndrome. So this is comparatively rare in ILD, DAD pattern. But if DAD pattern is there, these patients are highly toxic, they are sick, they are mostly in respiratory failure, and their life expectancy is very short, maybe in only few months or even few weeks. So we have already discussed, I think, this UIP thing, that there is a lot of fibrosis and you have a clinical implications because you can only offer them antifibrotics and not immunomodulatory drugs. Compared to a NSIP where there is a lot of ground glassing and less architectural distortion, these are usually associated with connective tissue or the drug-related ILD. Organizing pneumonia we have already discussed. These are peripheral patchy perilobular consolidations with the reverse halo sign. In hypersensitivity pneumonitis, you may have a mosaic attenuation. air trapping on expiratory images, and there are centrilobular nodules. These pattern recognition shows the differential and directly targeted the various investigations and treatment. Now coming to the management of ILD, once we have labeled an ILD, we have found out some pattern, we have fit it into some pattern. How to fit it and who can fit it? The most important thing till date which has proven results in a, as far as management of ILD is concerned, is multidisciplinary approach. No single person can treat ILD. Multidisciplinary approach means there has to be a discussion between a pulmonologist, radiologist and a pathologist to improve the diagnostic accuracy. It has to be decided between a clinico-radiological diagnosis versus a need for histology. When to take a histology or should be directly treat on basis of HRCT. Then shared decision making about the diagnostic procedures based on this risk and benefit. And if there is a suspicion of connective tissue disorder, then the role of rheumatologist also come into picture. So these are the four persons which have to basically, it's just like a tumor board. In any malignancy patient, if you go to any referral center, there will be a tumor board, there will be a radiation expert, surgeon and a medical oncologist who will be sitting on that tumor board and then decide on every single case, whatever simple or difficult oncology case comes to their picture. So same thing goes with ILD. These are the persons. Till date in my own practice, I discuss every ILD case with my radiologist. At least have a discussion of minimum 10 minutes on every single thing. I give her a history. She tells me everything about whatever whatever patterns she is seeing, what are the thing, and then we make a shared decision making. And then if required and we take a histopathology sample, then we rope in a pathologist also. This is a standard practice at most of the places to manage a ILD. Now coming to the very, very important thing like role of bronchoscopy, BAL and biopsy. In bronchoscopy, the bronchoalveolar lavage may support diagnosis, especially in hypersensitive pneumonitis, where you may have a lot of lymphocytosis and altered CD4, CD8. There will be a lot of CD8 cells compared to CD4 cells in BAL, in hypersensitive pneumonitis. In hypersensitive pneumonitis, even a biopsy, simple transbronchial lung biopsy, or in sarcoidosis, a simple transbronchial lung biopsy can make a definitive diagnosis of hypersensitive pneumonitis and sarcoidosis. But nowadays in NSIP and other things, lot of centers are trying transbronchial lung cryobiopsies. Earlier, whenever we used to do a transbronchial biopsy in ILD, the sample was never enough. So always a surgical lung biopsy was the diagnostic test of choice and bronchoscopy was not offered. With coming of cryobiopsies, now we are offering a transbronchial cryobiopsies. The only problem is chances of hemoptysis is pretty high. But otherwise, if the bleeding doesn't happen, nowadays we get a larger chunks and we can label most of the ILDs with the a proper pathology also. The gold standard is always surgical lung biopsy, but whenever there is no histology, whenever we require an histology, whenever we are not sure about the any ILD, or if it is a rapidly progressive ILD, then we offer the surgical lung biopsy. Not going to nudging. So management principles, the most important things in management principles. Always look for the treatable of like identifiable cause. Any drug, any antigen, like in pigeon breeders disease, the most important thing I always advise them is to change the house. It is, even if you tell them to just remove the pigeons from that house, it is not enough. The antigens, the feathers, the bird droppings, they stay on their beddings, on their bed sheets, on their clothes for at least a year or even 1 year and a half. And these patients may still have an exposure even after proper cleaning, multiple times of cleaning rounds of their houses, removing all the birds, cats, everything. They may have continued exposure for a year or so, even more than a year. So we always tell them, if possible, change the house. If they are not able to change, then obviously for few months I have always advised them to remain away from this thing, because these are the most dreaded diseases, the hypersensitivity pneumonitis. If they have a continued exposure, ultimately we will lose this patient in few years. Then coming to the drugs, if there is a specific drug, you can always change the drug to a pulmonary safe drug. And if there is a connective tissue disorder, start treating connective tissue disorder, your ILD will improve, or it will at least stabilize. Just like in RA, in connective tissue, ILD is the most common disease in India. It will be, I think, RA, rheumatoid arthritis. So you just treat the rheumatoid arthritis on standard lines like DMARDs, methotrexate, with the small doses of steroids, and if required you can add rituximab or something, and all of these drugs they will also help. The same treatment will work on the ILD part also. Then coming to antifibrotic therapies. In antifibrotic therapies, most important being the nintedanib and pirfenidone, and these are specifically for IPF. These drugs were basically researched for IPF, but nowadays any progressive fibrosing ILD, including hypersensitive pneumonitis and systemic sclerosis induced ILDs, mixed connective tissue disorder ILDs, we are offering these drugs wherever there is a significant fibrosis on HRCT. So these are the antifibrotic therapies. There are a lot of new drugs coming, including lot of you can say sisters of nintedanib. Lot of things are on research in India which is happening. Maybe another 2-3 years we will find some new drugs also. But nowadays the two important drugs which are available is nintedanib and pirfenidone. We should know the side effects of these two drugs. The nintedanib, the most important side effect is diarrhea, and pirfenidone, the most important side effect is hepatotoxicity and photosensitivity. So these are the common side effects of these two drugs. Immunomodulatory therapy, the most important being corticosteroids and steroid sparing agents including azoran, mycophenolate and cyclophosphamide. Nowadays we are not using cyclophosphamide much. Mycophenolate has already taken role. So most of these patients, non-RA patients like MCTD, Sjogren's, connective tissues, SS, we preferably offer them mycophenolate along with steroids at the first go, and most of these patients usually do well on mycophenolate. A careful patient selection should be there. Some fibrotic ILDs do not respond, and in some patient immunosuppression may harm. We have already discussed that, especially in IPF. Any patient who has lot of fibrosis, less of ground glassing, these patients may not respond well to immunosuppression, and you may have that side effects of immunosuppression. So whenever there is CTD ILD, always coordinate with the rheumatology for a disease specific regimens. Then coming to the supportive care. Once we have started on the medical therapy, then supportive care is also important. Any patient who has a saturation, resting saturation less than 89%, these patients are a candidate for long-term oxygen therapy. And then there is also a role of pulmonary rehabilitation in these patients and role of vaccination. All pulmonary patients, they should be routinely vaccinated for pneumococcal, influenza and COVID. This is a standard. Then early referral for lung transplant evaluation, especially the disease which is progressing, they should be early referral to lung transplant. Nowadays in India, more than 1,000 cases of lung transplant has already happened. So nowadays lot of centers are coming with lung transplant, the biggest being in Hyderabad. So you can always refer these patients to and enlist for lung transplant. Then coming to palliative care and symptom management as the disease progresses, just like any chronic disease. So all of these patients should be serially monitored with the PFTs, diffusion capacity, 6-minute walk test, oxygen saturation, and maybe a serial HRCTs also as indicated. Then we have to basically see the progression of the disease. The most important progression we see is on the symptoms and PFTs and diffusion capacities functionally, and sometimes on if we have to do a repeated HRCT also, on the radiologically also we can see the progression. And if the fibrosis is increasing, we can always add an antifibrotic drugs, and always individualize the follow-up frequency based on the symptoms and trajectory. ILD is a varied disease. Some patient, they progress very, very fast. Within few months, I have lost a patient from the just diagnosis till treatment. Even they were regularly on follow-up, taking proper medication, properly compliant. I have lost them in a year or so. I have also seen the same ILD, 10 years of follow-up. I have also seen 4-5 patients of where I am not offering any therapy. I am just giving them like 6 monthly, I am monitoring their PFTs and diffusion. They are just not progressing. So it is just like malignancy. Some of these patients may progress very fast. Some of them progress very slow. So if they are progressing very slow, the treatment, your intensity will also be low. Coming to the prognostic factors, any baseline and change in FPF, FVC and DLC are very, very key predictors. Extent of fibrosis, especially the presence of honeycombing, it indicates a worse outcomes, and comorbidities. Presence of pulmonary hypertension, it is a bad sign. Presence of a coronary disease, they also worsen the prognosis. So let's go into the summary. Today's whatever like we have discussed. So any ILD patient, we require a history, an examination, baseline PFTs and lab. Then the most important thing being the HRCT. If there is a definitive UIP, directly label it as an IPF with absence of connective tissue and consider clinical diagnosis and antifibrotic therapy. If it is a non-diagnostic HRCT, then go for multidisciplinary therapy, may consider TBLB, BAL, serology, other investigations. And treat the cause if found, if particular drug or there is some exposure to like cat, birds, something, then you need to eliminate that allergen. Immunosuppression for inflammatory ILDs, antifibrotic for progressive fibrosing phenotypes, and supportive care and transplant referral whenever indicated. So these are the selected references I've got. Thank you for the patient listening.